Well, welcome to the first session of Orange City Area Health System Daily Briefing, or perhaps maybe I shouldn't call it a daily briefing, maybe periodic briefing is better. This is where we like to spend a little bit of time with anybody who's interested to learn about updates on the COVID-19 outbreak, or what's the latest that's happening locally, particularly regarding the outbreak, and particularly our preparations for it here at Orange City Area Health System. This is obviously an extremely fluid situation. Things change literally by the hour, and our plan is to have a guest each day to assist us in providing an expert opinion. Today, my guest kicking it off with a good deal of zeal and zest is my good friend, Dr. Laird. For those of you that may not know, a few years ago, Dr. Laird and I played football together at Northwestern College. I think, Al, that was about like the first year after leather helmets.
That sounds right. I think we were still using candles and quills in the study hall. So
yeah, so it was a few years ago. Yes. That we played, but I've known Al ever since, and he's a great friend and even a better doctor. So we're very fortunate to have him here. What we're going to do is tag team a few questions here that we've received from the community and other points of interest that we think that you may have at this point. So we're just going to start in no particular order and go through these questions. The first one I do have for Dr. Laird is, why don't we have more ventilators or respirators, and why do we only have a ventilator for transferring patients?
I think that's a very good question. Thank you, Marty, for the nice introduction, and really appreciate the years that we've had in friendship. And it's a privilege to work with those here at Orange City Area Health System, from those in administration to those who are providers, nurses on the floor, and everyone else. The question about the respirator or ventilator, first of all, revolves around what are our needs today. We have one currently for transport because we don't provide ventilation or respiration long-term on an ongoing basis. We certainly do in surgery when you go to sleep, and we have people that are very familiar with that, but those are all meant to be short-term. And if you come in and need a ventilatory assist and need it for a duration of a few hours till we can get you where you need to be, that's what our needs have always been up until today. Obviously, with the concerns for the COVID pandemic and the amount of people that have wound up on respirators, that has raised an issue of what about if we need more than the standard amount? So that's a complicated question. It would be nice if we could just go out and buy a ventilator and you put it in your hospital and shazam, it takes care of everybody that comes in that needs one. But that's certainly far from the case. We need specialty people who run these and do it on a regular basis and are familiar with them. We do have respiratory therapists here. They are trained in using ventilators, but again, largely here we've only done short-term and not long-term ventilation. So if we were to get more ventilators, we would need people that could run them, understand them, and be available 24/7 to adjust them to the patient and the patient's needs, to also be able then to get one patient off of it and the next patient onto it. We would need support of people who can keep you asleep, because ideally you would be sedated on that. So we would need people who would be able to, again, 24/7 provide that sedation to the patient. So it's not just about the respirator, it's also about the staff that's needed to provide those. And that's something that takes training and learning over time. At this point in time, we still feel that there is not any immediate shortage at any of our referral hospitals, whether it's to Sioux Falls or Sioux City or even longer distances, that there's still buffer and availability for those resources where you're going to be better handled, and with staff that do it on a routine basis. So for that reason, at this point, we only have the one respirator, but that doesn't mean we aren't making plans and looking to the future and anticipating, if things really get bad, how we fill those needs.
Yeah, let's talk about that, because the next question is regarding what happens during a surge. And so a question that was submitted is, does the hospital have enough PPE, that's personal protective equipment, and beds if we have a surge? Now, one of the things that I can introduce here, because at an administrative level, I understand that our relationship with Sanford is there. And of course, we also can use Sioux City hospitals too. There's no hesitancy to do that at all. But I am more familiar with what Sanford is planning currently. And it is their intent to house all of our COVID patients as needed, and particularly those if ventilator support is required for all the reasons that you gave. Their willingness to accept those patients is well within their capacity right now, and their future projections as well. What we would offer in that equation then is acceptance of med-surg patients, where we might take some of their non-COVID patients and house them here in exchange for them taking some of our COVID patients and housing them there. And so that's another one of the reasons is for ventilators is we want those ventilators in the hands of people that run them every day for the protection of everyone involved. So Dr. Laird, would you like to talk a little bit about our provision of personal protective equipment at this point?
Absolutely. That is something we've rolled out, and if you've had the opportunity for one reason or another to be either at the hospital or at the clinic, you've probably seen people wearing things that they usually don't wear. And so far, we have been blessed to have an adequate supply. We have been supported by businesses and other members in the community that have donated and helped us get to where we needed to be with that. And at this time, we aren't projecting any shortage. That doesn't mean we aren't monitoring on a daily basis how much we're going through. And as things become busier, we expect to go through more. So there are models out there that we can use and have been using to project what our needs are. We continue to recruit and procure those things that we need. An example would be that we started to not by any means run out, but become a little short on hand sanitizer. And so we went out to other opportunities to obtain that, and now we have a good supply of that again. So the people in materials management, administration, all those people in the supply chain have been fantastic to work with. They're helping us out. We are also instituting measures to try to conserve protective equipment where it's needed, where maybe you aren't as exposed to the COVID virus or to other patients that require you to wear that. So we're trying to conserve as well as project, as well as procure, and that's an ongoing everyday activity.
Yeah, thank you. Another issue that's been out there a little bit is what is the bed size of Orange City Area Health System? What is the capacity? And as a critical access hospital, the maximum number of beds that you can have is 25. Also within that 25 bed limit is a maximum average length of stay of 4 days or less. Both of those regulations right now have been waived, have been set aside. So there is no cap on the number of beds that we can have. There is no cap on the length of stay that we may have also on it, and that's computed on an average basis. So just as an example, when I mentioned about the potential surge, we could go as high as 35, 40 beds here probably in our facility, using every nook and cranny and every proper place to care for patients with extra beds that we have, extra gurneys that we have. And so our capacity is not limited any longer to 25. And again, if those people are med-surg patients or non-COVID patients, they can cohabitate a little closer and in a little safer environment than with the extra precautions that are necessary with COVID patients. So one more question on the supply area, and what is your understanding about our oxygen level at this point?
Again, my understanding, and it's something that we look at and continue to monitor, is that at this point we do not have any shortage, and even projecting forward, we do not anticipate any problems for those patients that would need it. But do remember, not every patient with COVID is going to need oxygen. That's going to be a minority of the patients. As people have heard routinely, 80% of the folks will probably have a mild cold. Then the other 20% will break down to those that need hospital beds, which is around 14% by best guesses, 5% needing an intensive care unit, and 1 to 2% needing a ventilator. So for certain, if you're on a ventilator, you need oxygen. in the ICU bed, you may need oxygen, you may not. And then if you're on a standard floor bed, oftentimes those folks may not need the oxygen. So at this point, by our projections, we don't anticipate a shortage of oxygen.
Great. Let's talk a little bit about testing right now. One of the things that we are committed to share is what's going on in our facility in terms of testing. Yeah, you see all kinds of stuff nationally about what's going on in testing. You see these large numbers and this and that. What does that mean locally? As of an hour ago, I believe the numbers are still correct. We have tested a total of 39 patients, 39. Of those 39 patients, 32 have been negative, 3 have been positive, and 4 are currently pending. And so, again, negative 32, positive 3, pending 4, and out of a total tests of 39. So we will continue to share those numbers as often as we communicate with you. We hear a lot, Dr. Laird, about rapid testing and self-testing kits. Can you give us kind of the latest on that?
Certainly. Self-testing kits, while they sound wonderful, are a little more dubious, and I think further down the line, there's always issues of technique and how you obtain the sample, and therefore I think it'll be a while till we see any kind of self-testing kit. However, for those that are rapid testing, my understanding is one company has now been approved by the FDA and is manufacturing those types of tests as fast as they can. Rapid being up to 5 minutes to know if it's positive and up to 15 minutes to know if it's negative. And so we have done daily inquiries with that company about what availability is. Now, obviously, there are areas of much bigger need in the country than Orange City right now. New York, Los Angeles, Louisiana. I'm sure these people should have priority. And so some of those tests are not going to necessarily be available to us right away because there's only so fast you can manufacture them. Having said that, as soon as they are available to us, that's something we would like to have, and it will make it easier rather than 24, 48, sometimes up to 72 hours waiting for a test to return. And for that reason, I should also point out that we'll continue to follow the Iowa Department of Health guidelines on who we should test, who qualifies for testing. And then even after meeting those criteria, we have the conversation as to whether it'll make a difference in how we treat you or not, as to whether we should test, because we still are trying to be judicious about the kits that we have because of the need all over the United States.
And Dr. Laird is the Gestapo here at our facility, and he's the one that is ensuring that we follow the same criteria with every single patient in issuing our testing kits.
Yes.
At this point. And so that's an extra burden that Dr. Laird's carrying, but you can be assured that we are executing the usage of those kits across lines that are consistent and, as you said, CDC authorized. I think it's also important to underscore that oftentimes, well, in fact, probably most times, the treatment does not matter in terms of positive or negative. That the recommended course of treatment is exactly the same, whether you have positive or negative tests, and that is known by all of our physicians and clinicians here, and is being administered uniformly as well. Again, most of the time, those are most properly received, those treatments are received at home. And most times that's a lowercase t on treatment, we might say, and it's isolation and hydrating and things like that. And
absolutely.
I'm not a physician, but I did hang out with this guy for quite a few years now, so I got a few ideas. But I think it's really important to understand that if you're having some symptoms, you're going to be treated exactly the same way on whether you have a positive or negative test. I wanted to talk a little bit. Well, first of all, there's a question about when, and this is the $1 million question, right? So when is it going to peak in Iowa? Could you give us the latest on what your data, your information is saying on the worst? When is it going to peak?
Yeah. Lots of different models out there, and it depends on which one you choose to look at. But right now, from what I understand, is late April, early May is still felt to be the likely peak in Iowa. I know South Dakota to our north has projected theirs a little further down the line, possibly late May, early June. And again, it depends on which model you look at. But right now, we're anticipating that we're still in the early phase. And nobody, of course, knows what that peak's going to be either. And we won't know what the peak is till we're past it. So it's a little hard to know exactly when and how, but right now, most of the models are pointing to right around the 1st of May.
And so we all want to hang in there right now with social distancing measures. We implore all of you to practice good distancing. Dr. Laird and I are as close to 6 feet apart as we possibly can be here at this point. We're trying to model that here within the organization, and we certainly want to model that and ask the community to model that throughout their daily life. So please wash your hands, wear a mask if you want to go to the grocery store, that kind of thing. And we'll talk more. Well, in fact, let's talk about it now. If we are urged to wear masks in public, what kind should we have and where do we get them? Great question. Keep in mind that probably a handkerchief is better than nothing, all right? But what we want to make sure the public looks towards in that guidance is all the information that's on the CHP Community Health Partners for Public Health website in terms of what kind of masks to wear, where you might get them. Most likely the masks that the public would wear would be masks that are made. And please look at the public health guidance for that, IDPH, CHP, and they will guide you through that. I think it's reasonable to expect that you're going to see more of that in the future. And you know, there's nothing wrong with that. It certainly isn't going to hurt anything to do that, and may be uncomfortable. But we don't want to give a lot of advice here on how to construct those masks. Please look at your CHP public health sites, and they'll take care of that for you. Another question that we had is regarding, I'll just read it. Since we have extra medical personnel here, would we send them to places where they are desperately needed? Well, first of all, I don't think anybody has said that we have extra medical personnel here. In fact, we don't. And our surge plans indicate that we need everybody. And so we are not with a plethora of staff here. In fact, the words or the phrase that we use is our benches are not deep. Our bench is not deep. And that isn't a negative towards our staff. It's just a reality of well, really providers everywhere. Yes. At this point, but certainly in rural areas, the number of nurses, the number of physicians, the number of caregivers, number of dietary folks are not where you can just order a few more from the national stockpile right somewhere. And so we don't believe that we have excess personnel, nor have we denied anybody's request to go to New York City at this point either. But so that's that. I don't believe we have excess. But on the same token, we're setting very well in terms of where we're at in our preparation. Well, Dr. Laird, I think I have one more issue, and that's a question of most of you probably realize that we're making calls to patients of ours who are 70 years and older. And one of the questions is, are we making calls to people under 70 as well? One of the things that we want to make sure that we do is find people that have fallen through the net somewhere and that have a medical need, a food need, or a social, emotional, spiritual need. And we believe we're doing a pretty good job so far of going through our list of 70 and above and checking in with folks. And I know one of the phone calls that we had was 31 minutes the other day. So it makes it a little harder in the day to get through the whole list, but that 31 minutes was 31 minutes very well spent. And it probably has had as much to do with the social part of this as anything. But what I want to make sure that for those of you who may not have received a call or who are under age 70 and haven't received a call, to please remember that we're providing 737-2000, which is our clinic number. It's staffed throughout the day, and we have the capacity there for a lot of phone calls, 1,000+ calls in a day. We have the capability, we have people there. We'll take your message. There's forms to fill out where we can route your request to the right person. Again, anything from medications to medical concerns to I need somebody to run and get some groceries for me. We have teams and folks in place to be able to execute on all those needs. So remember 737-2000 if there's anybody in need that we haven't got to. The other thing is there's also some concern in the community that's been expressed. Well, the doctor just said, or the physician assistant or the nurse practitioner just sent me home and said, you know, you're best taking care of yourself at home. That should not be interpreted as don't call us if things get worse. And the thing is, we are always here to answer the question. 737-2000, again, you get to your triage nurses. But after hours, weekends, etc., the 737-4984 number will always go to a medical professional in our emergency department or on the nursing floor. And so by all means, if there are concerns that goes beyond what you feel comfortable with, please call that number, and we have folks here that will take care of you. I think that's going to probably wrap it up for today, Dr. Laird.
Very good.
Do you have anything that you'd like to add for today?
Stay safe, everybody. Stay encouraged. We're pulling together. We'll get through this. It's possible. We're going to see the other side. And I just, again, appreciate the great people I get to work here and the great people I get to take care of. It's truly a privilege.
Thanks, everyone. Hopefully you find this helpful, and we'll be back in touch with you as soon as we receive more of your questions. Thank you.